Hello again, it's Michelle Carmody from ACOM Health. I want to thank everyone for joining us for today's webinar with Dr. Mario Fuccineri. We're going to be starting here in just a few minutes on treatment plans and treatment goals, and hopefully offer some valuable information that you can take with you and start implementing in your practice as soon as possible. Dr. Fuccineri is coming to us with lots of great experience as well as wisdom to share with you in the profession of chiropractic. And keep note that we will be putting on ongoing series of webinars just to educate and promote this type of information across the country. So encourage your colleagues and friends to register for the next webinar, or forward over your invitation that we send over to you and encourage them to register as well. And again, we'll just start in just a few, well, really in just one more minute. I would like to go ahead and introduce Dr. Mario Fuccineri and educate you a little bit more about what type of experience he has under his belt. Very busy man, lectures all over the country for NCMIC and foot levelers and many state associations in his spare time, as well as teaching over at Logan College, and even, like he was sharing with me earlier, even doing exams with those students over there. So the gentleman stays very, very busy, including his own state organization, the Illinois Chiropractic Society, where he also was past president and is also the current Medicare chairman of Illinois Chiropractic Society. One of the biggest feathers, I think, in his cap is also being a medical compliance instructor and specialist. This is something that's a very rare type of specialty and certification, and very nice that Dr. Fuccineri is able to spend time with us, review his information, because he teaches this all over the country. He also runs a very active practice there in Decatur, Illinois, treating anywhere from 60 to 80 patients a day. So, Dr. Fuccineri, thank you again for taking time out of your busy day and, updating us on the different things that are going on in the industry. But really, strategically, we're talking about all these different notes, the SOAP note portion and the initial reports. But I think really going into the more the treatment goals and treatment plans and, the treatment frequency and things like that, too, to educate these doctors further. Anything else you'd like to add before I start with some polling questions?
Well, welcome everybody, and I hope that you can hear me well. I have a tendency to quiet down sometimes, so Michelle, feel free to tell me to speak up anytime, okay? Since I'm used to my wife telling me to shut up. So, when I was talking with ACOM Health and talking to them about the type of webinars we should be doing, it has come to my attention that there are some shortfalls that chiropractors have in their documentation, and so that's why we've talked about consultation, we've talked about the examination, and today we'll talk about treatment goals, and the treatment goals as well as treatment plan. And what's new in our paradigm thinking here is the care plan. Next month, as a matter of fact, we're actually in 2 months now, since we're actually going to be doing another one of these webinars. You might want to put it on your calendar for June 17th, and tentatively we are planning to talk about PART, P-A-R-T, which is for Medicare. Sometimes you don't know what you don't know, and people think they know PART and they don't have it until Medicare catches them, and then you have to pay back money. So I will have my whole webinar next time relating just to PART. So Michelle, I'll let you take it on, and we can get started with the polling questions first.
Sounds good. I'm going to go ahead and launch our first poll. And what I want to do is have you just answer real quickly, how many of Dr. Fuccineri's webinars have you attended? He's done 3. Today would be the 3rd one, of course. But we started with proving medical necessity. The second one was on documenting the examination. And today we're doing treatment goals. I'll go ahead and wait just a few seconds more, and then I'll close this poll. I think I've got just about everyone who's voted. I'm going to go ahead and close this poll. And let me go ahead and share these results with you. Looks like we've got about 52%. This is their first time joining one of your webinars, Dr. Fuccineri.
Well, welcome. Did I get
Yeah,
use my old jokes again?
And we've got 44% that have been to 2 of them, either today or one of the previous ones, and only 4% have been to all 3. Kudos to the 4%. I think this is great. Again, share these invitations that we send to you to your colleagues. We'd love to be able to educate more on a wider scale here. Let me go ahead and launch the second poll. When do you spend time getting caught up on your notes, your reports, your daily activities of your documentation? Do you do these right when you finish treating your patients? Maybe you spend your lunch hours doing this. Or maybe you're one of those that also does it after hours, like when you're done with treating your patients or on the weekends. Or you just never feel caught up, constantly behind. We've got about 75% voted. Wait a few more seconds. All right, I'm going to go ahead and close this poll. And let me share these results with you. What's interesting is that it's got 39% are completing their notes when they're done treating with their patients. Kudos to you. I think that's great. You've got some good organization, and hopefully these notes are also helping you a great deal of staying compliant and keeping those denials under wraps. We've got about 27% that never feel caught up. Definitely you want to look at some technology that ought to give you a helping hand on that. You can also take a look at our rapid documentation software to help you with that aid. We've got about 18% that do it after hours. I guess this is when you're done treating and you really aren't seeing anyone and you're just still doing your notes around the weekend. And then we've got about 16% doing it during lunch breaks. What do you think there, Dr. Fuccineri?
Well, notes can be completed when they're done treating the patients, but I would love to see the notes. Sometimes a travel card, even though it's done, just doesn't complete everything that should be, and I would welcome them to look at what we're talking about here today and see if, even with the treatment plan, the P portion of the note as well as your consultation, if you're doing what I have recommended here, and if you are, that's great. If not, then we can always, it's just one of the things I always say now is sometimes you just don't know what you don't know.
Right, exactly. Well, I'm going to go ahead and change presenter over to you so you can go ahead and take over the screen and start educating.
All righty. So you should see my screen coming up in momentarily here. There we go. Okay, so I'm going to take it away. Hopefully everybody can hear me, and welcome on this great afternoon, and for those of you out on the West Coast for this late morning here. And we're going to be talking about ACOMS, rapid EMR, and the treatment plan and documentation. And so if you have been with me in the last 2 webinars, you'll recognize this equation, and I like to use this equation to remind people that your subjective plus your objective equals your assessment, and then that leads to or yields your treatment plan. And that's what we're going to talk about here today. And just for those of you that are first-timers, welcome, and just to kind of catch you up a little bit, we talked first of all about the general questions that have to be answered in your SOAP note here. The subjective, it's what's going on. Objective would be what did you find? And so what's going on, this is what the patient tells you, and then you become the scientist, and in objective you're using your senses of what did you see, what did you feel, touch, and smell even. We don't usually taste our patients. And then the subjective and the objective together, those lead to our assessment. And assessment, and remember, especially on the first webinar, we talked about assessment proving medical necessity. If you write down for your assessment either patient is improved or patient is improving as expected, and some doctors, all I see them do is reiterate what the diagnosis is, then you will probably find that upon audit it says medical necessity was not shown. If you ever get back an EOB or some type of denial and it says medical necessity was not shown, the first thing I want you to do is look at your assessment. And in the assessment, you have to answer 2 questions every single day, and that's for every region you treat. Those 2 questions are, the patient is improving, how? The patient needs care, why? And if you can answer that, then you have shown medical necessity by definition. So the patient is improving with decreased edema, decreased nerve root tension signs, but still has spasms, tenderness, and subluxation at L5. And then from that, it'll lead to what you're going to do, and what you're doing is what are you going to do about it is what I say, and that's your treatment plan itself. So the treatment plan really, nowadays, the treatment plan consists of 3 different portions. The first portion of the treatment plan is the frequency of care. And then it goes into the treatment goals, and then the care plan. And that's new nowadays. Most people don't know what the care plan is, and so what we're going to do is we're going to talk about these 3 things here in our short amount of time over the next half hour. So frequency, I think most chiropractors, it's 3 times a week till they drop dead. That's not a good treatment plan, by the way. Or 3 times per week for 2 weeks, then 2 times per week for 2 weeks. Now, normally what we find in all insurances, and even cash, because it's not just about insurance, it's also about liability and making sure that with liability you have proper documentation to prove what you're doing and so that you're not negligent. And so normally what we will do under active care, we will set the patient up for a treatment plan of about 4 to 6 weeks. And so 30 to 45 days, 10 to 12 visits, up to 16 visits is necessary. Let me give you a little example here. I recently did an audit, and when I talk about doing an audit of a doctor's office, what happens is that I actually am hired by the doctor. I go in, and they say, please come in, check my notes for me, check my office, see what I'm doing wrong, and let me know so I can correct it before somebody else finds out. And so I'll look, in one office I went to, the doctor, I pulled a file at random, and this was in October, and the doctor had seen the patient 163 times so far in 2009. Now, 163 times, and hopefully most of you are just kind of shaking your heads saying, oh my. I mean, because they're not even a patient then, that's family, right? But for me, it was really easy to audit those notes because the first question I had to myself was, okay, when was the reexamination? There was no reexamination. So normally, we give the doctor about 12 visits, and then everything after that is denied. And so you want to make sure that you have that reexamination as part of your treatment plan. What some doctors do is they will say 3 times a week for, 4 weeks, but they don't include that treatment plan. And so before you know it, you say to the patient, okay, let's see you Monday, let's see you Friday, and let's see you in 2 weeks. And then before you know it, it's months that have gone by and you never did an examination. So always make that reexamination part of the treatment plan. And so, for instance, in my office, we might use 3 times per week for 2 weeks, followed by 2 times per week for 2 weeks, then re-exam. And when your office is scheduling multiple appointments, what you can actually do is schedule that 11th appointment in this example here as an exam. In other words, we'll put the time and the date, and then we put REX for re-exam, and then that way the office knows, the doctor knows, the patient knows, we're going to be rechecking you at that time. And so the treatment frequency, the reexamination is very important portion of your treatment plan, all right? Then we go to a major portion, which is your treatment goals. And we're going to spend some time talking about treatment goals because treatment goals are, it's one of those nebulous things, kind of like what is life? And so let's talk about treatment goals. Now, I know you look at phases of healing, you think back to school, and you go, oh, gosh. But you know what? In the acute case, when a patient first comes in and they've injured themselves, it's nice to kind of understand the phases of healing, and let's just kind of review that really quickly here. First of all, there's the inflammation phase, and this is where we use the acronym, the RICE, which is rest, ice, compression, and elevation. And so what you want to do is you want to stop the inflammation process of the body, and so you're going to be using ice and resting the area. You're going to take them off of some of their activities of daily living, or perhaps off of work or light duty work in the meantime. Now, the next phase is called the repair phase. The repair phase takes up to 8 weeks. And I understand you'd like to tell some of these insurance companies there's no way that the patient can heal in 6 visits. Because look at this, the repair phase itself takes up to 8 weeks. And so here, this is where you're going to start to have the patient move, and you're going to try to support and help the new tissue formation using ultrasound, muscle stim, ice, whatever it might be. And so your treatment goals in the repair phase might be that you want to increase function, and you might well do some isometric exercises. And so keep in mind what phase the patient is in, and look at their proprioception too, and we'll talk about that. Next comes the remodeling phase, and in the remodeling phase, this is where you want to optimize tissue function, and you want to start to increase their ADLs or their sport. In other words, get them into functional exercises. This is your subacute phase. And so here you want to increase their ADLs or increase exercises so that they can have better activity without pain. In other words, we call that activity intolerance. I can't stand for longer than 30 minutes without pain. Well, let's get you stronger so you can stand longer than 30 minutes without pain. And so your treatment goals are very important depending on what phase that you're in. And so as the time progresses, your treatment goals are going to change. And you need to, as a doctor, you need to morph those treatment goals. And I always think of the stair step here. And, when we go on the stair step, the first step here is a short-term goal, maybe to decrease edema. And then, as the edema and the pain starts to decrease, then we're going to work perhaps to decrease spasms. And as your treatment goals change, each time that you change your short-term goal, you're kind of ascending the step, going up the steps. Now, so the patient's improving. Eventually, you're going to get them into better activities of daily living, and then what I call the landing of the step is kind of like your long-term goal, which means you've made it. And so each short-term goal depends on the patient's progression. And I actually, I have a very busy practice, and I turn it, lemons into a lemonade. And I will tell the patient, the patient says, my sharp pain is gone, but the stiffness is really bad. And I'll say, that's good. And they look at me like I'm nuts, but I'm used to that. Most people do, But the key is that I tell them it's good because you are in what we call the phases of healing, and when the stiffness fades away, you're out of pain. And because of that, you've graduated to a new phase, and we're going to change your therapy. And so, we take them from passive modalities, ice, interferential at the beginning, to ultrasound, whether it be pulsed or continuous, and then finally into rehabilitation. And the patient sees that they are progressing in their care. And it's nice, they need to know that they are progressing in that, and I tell them, and I honestly do, I just say, in my mind, I'm not discouraged at all. You are doing perfectly. You're right on target. Or you could be ahead of schedule depending on the patient. So keep in mind these stair steps here and how your short-term goals will work until finally you get to the long-term goals, which is to allow the patient to do activities that they're used to. So short-term goals, at least think of it in a realm of 2 weeks. And now, it's not on the slide, but just kind of hang with me. Don't read the slide here. Just listen to me first. When a patient comes into your care, then that patient should be improving within 2 weeks. And when I talk to doctors around the country, and I teach around the country, I ask them, I say, doctors, isn't it true that if a patient comes in after being under your care in 2 weeks, and they said, my pain is just as bad the first day as it is today, if there's no change at all, don't you think there's something wrong? I mean, maybe I should send them out for tests, or maybe I'm missing something. And that's because that patient should be improving in 2 weeks. Well, when you think about it, Mercy Conference guidelines, and I know they're old, outdated, but there's still good material in there. And Mercy Conference guidelines state that the patient should be improving within 2 weeks. And if they're not, you change what you're doing and try something different. If you change the modality, or change from passive care to active care, or go ahead and get an MRI or something, if you change what you're doing, then you might get better results. And that's what this is all about here, is just looking at those goals. So some of your short-term goals would be, for instance, those nerve root, the radiculopathy in their leg. And most patients will have decreased leg pain. Some of them, the pain will heal actually from proximal to distal. And that's okay. I tell them that the nerve is just healing down the course of the nerve, or to bring their pain levels down. We'll be talking about PART on our next webinar, June 17th. And in there, if I told you, hey, do you like what Medicare is paying you? No. You wish it was more. Well, how many of you ask on a scale of 0 to 10, what is the pain? Well, if you ask the patient their pain levels, Medicare, if you put in the correct code, Medicare will pay you 2% more. You'll say, ooh, how do I do that? Well, that's why you need to come to the next webinar, okay? But low back pain, consistently less than or equal to 6 out of 10 with activities. Resting low back pain, 2 out of 10. And then, of course, independent with basic self-care activities of daily living. Now, basic self-care, this is a good term here. I like this term. You know why? Because think about it, like most patients hopefully can wash themselves, can brush their teeth. But how many of your patients come in with slippers on, or have their shoes where they don't have tie shoes because their back pain is so great that they can't even bend over to tie their shoes? Well, you should note that. And when the patient comes in, and I've even had patients say, look, I've got normal shoes on now instead of their fuzzy slippers. And you see, that is improvement. And you want to show that the patient is improving. Patient is improving with independent ADLs. Patient is even able to wear regular tie shoes at this point. And see, this is what you expect on your patients within the first 2 weeks. Now, long-term goals, which could be 4 weeks or longer, will be low back pain at worst less than or equal to 4 out of 10. Patient will ambulate 15 minutes at 2.0 miles per hour without increased lower back pain. It's whatever their ADLs are. And we talked last month, we talked about outcomes assessment tests, and even the webinar before. And outcomes assessment are important. Any of you that talk about ADLs, you need to do, not you should, you must do outcomes assessment testing to objectively show where the patient has their problems with activities of daily living, and you quantify their impairment, and it's a functional impairment. Now, if you'll see on your screen, you might want to write this down here, number 5, to prepare the patient for a home-based exercise program. When you do exercises in the office with the patient, rehabilitation, if you're using special machines, you might get better results, but the problem is that when you tell the patient to go home and do their rehab exercises, they don't know where to start. And so I always believe in low-tech rehab classes, and I teach low-tech rehab classes all over for NCMIC and Foot Lovers. And so when I prepare the patient with their rehabilitation exercises, I always give them exercises in the office to learn so that they can now do it at home. And then once they get working better and they know, I call it a Jedi Master. In other words, they know these exercises. I say, okay, go ahead and do these at home and see me in whatever it might be, 1 week, 2 weeks, 3 weeks. And the patient will come back and I will see how they're progressing. And so that's why you always want to prepare the patient for a home-based exercise program. Now, that goal right there serves two purposes. Number one, it tells the insurance carrier, I intend to send them home with exercises, because sometimes the insurance carrier will say they could do those exercises at home. It's true, but it's called contributory negligence, which means if I send them home with exercises and they hurt themselves, I can be sued. And so therefore, I am instructing, overseeing their biomechanics while they're doing the exercises. And then once the patient has learned the instruction, then we'll send them home with the exercises. So this is always my last goal, my treatment goal, is to prepare the patient for a home-based exercise program. Now, just to kind of cue you in a little bit on some of the therapeutic exercises here, and hopefully there it is, 97110, therapeutic exercises. Now, what's interesting when you talk about treatment goals, if you look at the AMA book, and the AMA CPT book is the Bible. ChiroCode book is very good, but unfortunately, that is not, they look at the AMA's book and then they interpret things. And so when you look at treatment goals for 97110, therapeutic exercises, what are your treatment goals? And it must be, according to the CPT book, it says 97110 is used when, and you see this, when the treatment goals are to increase strength, endurance, functional capacity, range of motion, and flexibility. So again, your subjective plus your objective equals your assessment. Okay, what is your assessment? Does the patient have decreased strength, decreased endurance? How's their functional capacity, range of motion, flexibility? If they have any of these, that will go into your treatment goal of why you're doing these therapeutic exercises. In other words, if they don't have a loss of range of motion, don't put it down. But whatever they have, now your therapeutic exercises, the treatment goals goes more towards their ADLs, and what you're trying to do is increase their strength, endurance, functional capacity, range of motion, and or flexibility with the exercises that you're giving for treatment goals. Now, what's interesting is with neuromuscular reeducation. In neuromuscular reeducation, patients, this should come up on your slide momentarily. I see it trying to move. And there it is, 97112, neuromuscular reeducation. This is used when treatment goals are reeducation, improvement of proprioception, balance, coordination, kinesthetic sense, and posture. People wrongfully use this code for trigger point therapy. It is not for trigger point therapy. In fact, 97140 is for trigger point therapy. So neuromuscular reeducation is their proprioception, their balance. Interestingly, the Centers for Disease Control says that 68% of people over the age of 65 have a proprioception problem, their balance. And there are ways you can test it and are very easy. And I will tell you that when a patient has injury, proprioception is often deterred or detrimental to that patient. And so therefore, their kinesthetic sense, which is their kinetic chain, is disrupted, and so the patient will habitually have instability of their sacroiliac region as well as their hip, their knee, lower back, whatever it might be. So if you're doing 97112, and I understand that some insurance companies say, oh, this is just for stroke rehab. Well, that's the policy of that insurance carrier. It's not what the AMA CPT book says. But again, if you number one, have to show objectively that the patient has some problem with proprioception, and that's easy to do with testing. And number two is that now has to be in your treatment goals, which means you have to try to educate the patient by improving their static or dynamic balance, whether it's standing or sitting. And so that goes into your treatment goals. So 97112 is for proprioception. It's the wobble board, the BAP board. PNF stretching does qualify for 97112. So it's not so much what you're doing, but what I want you to do is to think about why you're doing this. This is what we're talking about, treatment goals. 97110 is for strength, endurance, flexibility. 97112 is for proprioception, for their balance. All right? All right. So that took us through the treatment frequency, 3 times a week for 4 weeks, then re-exam. Work that into the frequency. Then your treatment goals, both short-term and long-term, and then finally your care plan. What are you going to do and why are you doing it? Now your care plan. Now everyone, I can't hear you out there, so you're going to just talk to your computer. But when you look at the at this assessment, and this is a little bit more than I write each time, but it will drive home the message I'm trying to deliver here. First of all, diagnosis is the patient has a subacute cervical neuritis. Now the patient's improved with decreased pain and decreased edema. See, patient has improved how? Well, they have decreased pain, decreased edema. Patient needs care. Why? Well, they still have left C7-T1 facet inflammation. Now this is where I can't hear you, but on this case right here, would I use heat or ice? I would use ice. You don't use heat on an inflammation, right? Would I use interferential? Yes. Would I use ultrasound? How about in the pulse mode? See, now I can use ultrasound. Might I start to increase their ADLs and maybe start to increase some exercises? Sure. You see, by telling you what is wrong with the patient, you told me the care plan. And some of you may use acupuncture. You might use nutritional supplementation. You maybe use AK. Whatever your technique, it does not matter. It's how you're going to treat the patient, and based on your assessment, that yields your treatment plan. And the treatment plan, as we said, is broken down into 3 components, which is your treatment frequency, your short-term goals, long-term goals, as well as your care plan. So in the care plan itself, you can do, for instance, the adjusting procedures to be used. Maybe you want to do side posture. Maybe the patient cannot do side posture because they had rotator cuff surgery and they can't turn on that shoulder. Maybe you're going to do flexion distraction. Maybe you're going to do decompression therapy, whatever it might be. Okay, which modalities and why? Do you have to tell why you're going to use these modalities? Only the first time you introduce them. Interferential and ice is used to decrease inflammation, to decrease pain, and to allow the tissues to begin to promote healing. Well, then if I switch to pulse ultrasound, I'm using pulse ultrasound to decrease spasms, increase circulation, and decrease exudate and congestion within the tissues. And once I do that, then I just use the ultrasound. Does the patient still have any TTD, temporary total disability? That means restrictions. By the way, never ever take a patient off of work and put undetermined. As I teach people, think about what insurance company has the duck? It's Aflac. Well, Aflac is actually an accident policy. And if you listen to the commercial next time, it talks about Aflac where they say, the guy's sitting in a hammock with a cast on with the duck next to him. He loves the duck. Well, no kidding. It's because he says, Aflac pays my power bills. They pay my mortgage payment, my car payment, even my rent-a-center payment. Is there any incentive for him to go back to work, or her? No. So that's why for TTD, temporary total disability, if you're taking them off work, do it for a short amount of time. I rarely go beyond 3 to 7 days, if I do. All right. Home care recommended, such as exercises, ice, whatever it might be, any supports or pillows, nutritional recommendation. This can all go in your treatment plan. And then finally, explain procedures, risks, and alternatives. That would be with your outcomes assess. With your informed consent. Now, you'll see at the bottom of this slide here, it says on your plan. This is in your SOAP notes now. It would be record the segments adjusted. In Medicare, Medicare requires that you record the segments you adjusted each and every visit. In regular insurance, NCMIC, for instance, whom I teach for, they say that you should be putting down the segments and the technique you use. But part of our adjustment, our adjustments, if you will, split into 3 parts, which is pre-assessment, how is the patient doing, you palpate them, your manipulation, and then post-assessment, which is basically how are you doing. And your post-assessment, you would indicate that, and you'll see I have it in quotes here, patient-tolerated procedure without incident. You make sure that that is in your P portion of your notes, okay? All right. So we started alluding about Medicare, so let's talk about Medicare. If you took my class, the very first webinar, we talked about how to avoid an OIG or Medicare audit. And one of the things is to have an initial visit report. And we went through the symptoms, the family history, those things that should be generated in the report for Medicare. Medicare requires an initial visit report. You don't mail it in. It's part of your notes, but if they ask for the notes, you better have it. All right, then you go through your OPQRST, and then you talk about your objective findings, your diagnosis, and then finally, here it is, Medicare's treatment plan. And the treatment plan is the recommended level of care. And again, when Medicare says recommended level of care, they want to know segment, because they are stuck on segments. And so are you going to adjust L5? Because if you say L1 for sciatica, they say no, that doesn't work. L5, yes, it works. Your specific treatment goals. And then objective measure to evaluate treatment effectiveness. And think about it. What is an objective measure to evaluate treatment effectiveness? It's your outcomes assessment. It's all of it's your examination, your re-exam. So your treatment plan should always include a treatment, a re-examination. And of course, box 14 on Medicare is your initial date of treatment for Medicare, okay? I'm going to switch over, but I just wanted you to, if you have questions, we'll be talking about a way that you can get notes on these, on this class that I just presented here. But if you have questions too, I number one, invite you to check out the website. Keep in mind the schedule. Our next webinar will be June 17th, talking about PART. But don't cut out yet. Just hold on with me for 5 more minutes here. Because, and by the way, if you have any questions, you want to send it to doc@askmario.com. Doc, D-O-C, at askmario.com. But something in the subject where I put down ACOM webinar so I know it's you, okay? So let's go away from this for a second, and I want to take you into and kind of show you, this actually here is a very famous patient that we've been working on in all my webinars, and so it's not a HIPAA violation because he gave me permission. His name is Mario Fucineri. And in the ACOM, if you have the rapid EMR, you'll recognize this as the initial report, and as we go through, we can do the examination, and then we come to the recommendations. And so what I'm going to recommend to the patient, and folks, I'm doing this one-handed here, I'm going to recommend CMT, and so again, in my treatment plan, I might actually go ahead and say CMT at C7, T5, T10, L5, and the left SI. And rather than writing it all out or these check marks there, boom, there it is. It's CMT, which is chiropractic manipulative therapy, to the C7, L5, T5, T10, L5, and sacroiliac joint on the left per palpation. In the acute stage, well, what am I going to do? Well, as I said, in the acute stage, we're going to use interferential ICE, pulse ultrasound, as indicated. All right? And so it's right there. There are actually other macros that you can use here. There's other ways that you can pull up other treatment. In the subacute stage, now this is where we want to turn the patient into more active care. And so here I'm going to improve rehabilitation. And so that's in my recommendations opinion. You'll see down at the bottom right here, I'm going to say the patient's going to come in 3 times a week for 4 weeks. And then we go on to the next page here. And the next page now, we'll talk about the treatment that I'm going to do. And so the treatment, again, might be, CMT that I did that day, whatever it might be, okay? And so I'll say C7, L5 just for time here. And you'll notice it also has, I use mostly diversified technique and patient, PA, tolerated treatment, and there we go, Mario Fucineri, patient tolerated treatment without incident. Folks, it's this easy, and I know some of you, you say when I leave the room, It's already done, but I will tell you that are your notes done, but are they done properly? And so when we look to our report here, you'll see right now the software is churning, and it'll come up, and here is our initial evaluation. And it should be appearing on your screen right there. And this is in Microsoft Word, which means it could even be emailed. And what I just did here at the bottom, I'll say that the initial treatment today consisted of CMT at C7L5, patient-tolerated treatment without incident. The initial recommendations, patient is scheduled for 3 visits per week for 4 weeks, at which time a reevaluation will be performed to monitor treatment effectiveness and modify treatment plan as necessary. CMT to these regions per palpation. In the acute stage, use interferential ice, pulse ultrasound as indicated in subacute. Treatment will consist of specific spinal manipulation, appropriate adjunctive therapy, and instructions for stretching exercises to be done at home. Treatment goals are to decrease pain, spasms, and edema in the next 4 weeks, and then you sign it. And this is how easy, and folks, I'm doing this with one hand. Imagine now, this is like Rush Limbaugh says, one hand tied behind my back. All right, so imagine if I can go to 2. So 2 hands. So folks, it's easy to do if you do it right. I will tell you, if you do it right, even if they ask for the notes, just say, here you go, and watch. You will get paid. All right? All right, that is my class here, and we're going to turn over for questions. So Michelle, I'll have you come back on and take it over.
Thank you, Dr. Fuccineri. If there's any questions out in the audience today, if you can just jot down a quick question for me, send that over in the questions, and we can go ahead and get that taken care of real quick.
Michelle, while we're waiting, we might want to let them know how they can get the notes.
Yes. We have a nice compliment to everyone who registered for today's webinar, and that's live on the session. We will automatically send these over to you later on today. So you'll be getting them before the evening, and it'll be a list of, well, it'll be today's treatment goals, the entire notes done by Dr. Fuccineri. It'll be a nice little reference guide for you to go back to as reminders, but hopefully you've got a lot of great helpful tips from the information that was covered today. I do have one question for you that's come through. Can you sign without a signature on your documentation?
The answer is yes, and it's electronic signature, which ACOM's Rapid EMR does accommodate in several different ways here. Number one, what will happen is that in the electronic signature, and let's say in the daily notes, there's the actual area, and you don't have my screen anymore up on your screen, but there's an actual area where it says click here to sign this note. And so if you have a, like as we do, a write pad, in other words, a stylus pen or a touch screen on your laptop computer, you can sign the note. Medicare also says electronic signatures are good to, as long as they are time stamped, and if it's password protected. In other words, nobody else can go in. So you can actually say electronically signed by, and as long as it's password protected, that would be fine.
Thank you. Another question we got is, what outcome assessment and ADL sheet do you use?
I use Revise Us Westry. The most common, and it's not just me, in our profession, in the medical profession in general, the most common outcomes assessment testing is the Revise Us Westry, Roland Morris, or Neck Pain Disability Index. Roland Morris is more for acute lower back pain. Revise Us Westry is for chronic lower back pain. It doesn't really matter what you use at the beginning. It's just that on re-exam, you always use the same one. And the Neck Pain Disability is just for neck pain, no matter what stage. And so I use in my office Revise Us Westry and Neck Pain Disability. The outcomes assessment testing, what's really, I think, really cool is that it is built into ACOM's daily and initial notes now. And so the patient, in their kiosk, you can actually have the patient put it in, and it's already in there. If some of you I know nowadays who are, some of you are scanning your notes into the software, it's already there with ACOM. You don't have to scan. Think of all the hours scanning notes in and the outcomes assessment in. So it makes it really easy, and there's even a way that it can dump into your treatment goals. The program really is phenomenal.
Okay, thank you. One more, I think I have a couple more here. This documentation and treatment paradigm is incompatible with subluxation-based doctors. What do they do?
Why is it? It absolutely is compatible. Number one, what is your treatment goal? Why do you, subluxation is in your objective here, but why are you doing this? You're doing this to improve their function. I went to Palmer. I disagree with that completely. What you are doing here, you are, the way you treat the patient with manipulation and any adjunct therapies that you're doing, whether you send them home with exercise, nutritional, or anything, or just, you have to have them do something at home, exercise, that is subluxation based. But don't forget, your treatment goal is what outcome you're looking for. The way you do it is by removing the subluxation. And if you were here last time and come to my PART class also in June, and we talk all about the subluxation. I talked about the subluxation quite a bit in the first two webinars. So I'm sorry, I disagree with that.
Okay. Another question is there a way to hear previous webinars? What I would like to do is invite that any of the doctors that are on this webinar did not see the webinar on proving medical necessity or documenting the examination, be specific and email me. My email address will pop up after this webinar is concluded, and I'll be more than happy to get a copy of the recorded link to you specifically, but please help me and know which webinar specifically you're looking for, and I'll get that over to you.
And everybody, I'll just add, for the notes or previous webinars, don't email me because I don't have them. ACOM does. So, Michelle, you have to answer the emails.
I will. I will. Let's go ahead and just take one final question. Where can I get a copy of outcome assessment questionnaires?
You can get a copy of the, legally get a copy either from Stephen Yeoman's book, Y-E-O-M-A-N, Stephen Yeoman's book, which is Clinical Application of Outcomes Assessment. He also has his book, I believe, now on CD, or CD/DVD. Also, the ACA, American Chiropractic Association, sells the software program, which has every outcomes assessment testing, even for shoulders, knees, TMJ, whatever you might do, and that's at acatoday.com. And also, ACOM has it built into their software if you have the newer version of their software.
Yes, we do. I think we have 11 outcome assessments that are pre-populated in the software now. So that is a definite benefit to you. If you've always wanted to do outcome assessments, just need a more convenient way to do so. The Rapid documentation software, in conjunction with the Rapid Kiosk, it makes it really convenient for you to populate that information real quick and easy. I want to thank everyone for joining us today. We've had a great show of doctors registered and also attended for this treatment goals and treatment plans for today. I also want to make sure you jot your calendar for June 17th. Dr. Fucineri will be blessing us again with his presence and his knowledge to go over Medicare Part, how to document Medicare Part, how to use it and why and when, and also, to go over a lot of the I guess there's a lot of misinformation you shared with me earlier, Dr. Fucineri, about that's out there. Just to make sure everyone's on the right path. This is coming straight from one of our excellent advisors here, but as well as expert speakers that covers the country. Again, with his being sponsored and speaking for Foot Levelers, as well as NCMIC, National Chiropractic Mutual Insurance Company. I mean, I think that's great. Different companies to be supported, and also they also have him speaking at those engagements. But go ahead. I'm going to go ahead and conclude this webinar. Again, thank you for joining us. Send me an email over if you would like to get a copy of a previous webinar. I'd be happy to get that over to you. Just let me know which one you want, if it's for proving medical necessity or for documenting the examination. There will be a survey that's going to pop up as soon as you exit this webinar. Please take the time to fill that out. That way I can go ahead and get the notes over to you in a timely fashion. And there's only just a few questions, but it's going to help us a great deal in helping you further educating you more on future webinar courses that we put in with Dr. Fuccineri and other specialties as well. Thank you again, Dr. Fuccineri. I appreciate you, as always. I know you're a busy man, and we really appreciate you spending some time and educating the rest of the profession.
Thanks, everybody. You have a great day, and keep documenting.
Absolutely. Take care, everyone.